This conference will now be recorded.
Am I audible?
Yes, ma'am. Yes, ma'am. Audible, ma'am.
Thank you. So, good afternoon, everyone. Today our topic is about how to diagnose and how do you treat a case of tuberculosis. What are the investigations which we do in a case of tuberculosis? So, the investigations we collect some direct evidences and also indirect evidences to rule out tuberculosis. Direct is the isolation of the bacilli is the best thing to do. That is bacteriological examination for isolation of bacilli. You already know this. And histopathology is one of the direct evidence, and molecular diagnosis. These three are the direct evidences by which you can detect the tuberculosis, and indirect evidences are your biochemical other markers, immunological techniques, supportive investigations like tuberculin test and BCG tests, blood examinations, and radiology and family screening. So coming to the bacteriology, so we usually have a specimen to rule out or isolate an organism. So what is the most common thing in a tuberculosis? The sputum, which you are well versed. The sputum in an adult, it is usually we get it by expectoration. In a children, we can either take the gastric fluid because small kids or small children cannot expectorate or produce sputum. So we either take the gastric fluid or bronchial aspiration from the trachea and bronchi. So we want to take either bronchial aspiration or bronchial lavage, bronchial secretions from the trachea or the bronchi, and gastric fluid, which we routinely practice if sputum is not produced by the children. So how do you take this gastric fluid? By insertion of an NG tube, but it should be aspirated early in the morning, that is on the fasting stage, before the child swallows anything, before the child eats anything. Why this early morning is important is like the child swallows secretions all over the night, and we have to collect the gastric fluid for at least 3 days consecutively. The others are CSF. From the CSF, other serial fluids like any pleural effusion is there, you can do a pleural tap. Any abdominal TB ascites is there, you can take an ascitic tap. And urine examinations, and any pus is also localized pus, you can take an examination and isolate for the bacilli. So coming to the specimen is collected. So what do you want to do with the specimen? Jaden staining, Gill-Nielsen staining is the most commonly used staining, and other types of stains are Raman, Rodaman stain, and fluorescent microscopy. Sodium hydroxide, it is the liquefying agent which we use and digestant which we use in detecting the bacilli. So the concentration is obtained by centrifuging the specimen, and AFB in a concentration of greater than 10,000 per ml can be detected by smear examination. So any AFB in a 1 ml, if you take 1 ml sample of a say like gastric fluid or bronchial alveolar aspirate, if in 1 ml it is detected, sent for a smear, and if you detect more than 10,000 AFB concentrations, then it is positive. So Gill-Nielsen technique, first you take a microscope slide, and there you can see the specimen which you have collected. You will put it on the slide, and to fix the cells on the slide, you want to heat it. First heat it to fix the cells on the slide, then pour carbyl fusion stain on the slide. So flood the slide with carbyl fusion stain, and again heat the slide gently until it steams for about 5 minutes. Gently do the heating procedure again, and after that pour off the excess carbyl fusion, whichever is there, just you pour out and wash it in the tap water, rinsing water. you decolorize everything with acid alcohol and keep it for 20 to 30 seconds, decolorize it and wash again thoroughly with water, and next flood it with methylene blue counter stain for 1 minute and wash it with water. So blot the excess water and dry the slide. So you have used two stains on this, carbonyl fusion stain and the methylene blue stain. First heat the slide, pour carbonyl fusion, again heat the slide, pour for 5 minutes, pour off the excess, wash it under water, decolorize it completely with acid alcohol, wash it with water and add methylene blue, the second stain, counter stain. Keep it for 1 minute, wash it with water and dry the slide. So Oramen rhodamen stain, fluorescent microscopy. This flame slides to heat fix. So again we are preparing a slide, heating it, flood it with Oramen rhodamen stain, allow it for 20 minutes to stand, rinse with water, flood with 0.5% of acid alcohol and decolorize it. Rinse off the 0.5% acid alcohol with water and after that flood with potassium permanganate and allow for 1 minute. After that wash out the potassium permanganate. So you are using Oramen rhodamen stain and potassium permanganate with decolorization agent is acid alcohol. So coming to the culture, we have solid media, liquid media. Solid media are the Lowenstein-Jensen medium, Dorsets medium and the Petrov's medium. Liquid media are Middlebrooks medium. What are the disadvantages of this media? It is difficult to collect sputum, CSF and others. And the major disadvantage is it takes 8 weeks for result. 8 weeks is quite a long time. In the 8 weeks period, your pulmonary TB may worsen. 2 to 8 weeks for result. So if the condition, general condition may worsen, it will be multiplying. So only 5%, and after waiting that only 5% results may come true positive sometimes. These are the major disadvantages which we observe. So recent culture techniques. So we have brought advances in the culture. Backtech, this is the routinely used now. Radiometric culture system, it is a radiometric culture system. Duration is 2 weeks, max of 2 weeks or the end of 1 week to 2 weeks. And radio label substrate is used. Growth of AFB is detected radiometrically by measuring the metabolite radio label CO2 that is released. So the AFB detected by the radiolabeled CO2 that is released, and septic check. This uses modified Weddell broth is used. Rapid slide culture method is the method which we use, and Mycobacterium growth inhibitor tubes are used. Coming to the histopathology, histological examination show evidence of delayed hypersensitivity reaction. Classical appearance of caseating necrosis is classical for a TB. Tuberculosis follicle consists of central caseous necrosis, and the central caseous necrosis is surrounded by lymphocytes and multinucleate giant cells and epithelioid macrophages. So central caseous necrosis surrounded by lymphocytes, epithelial cells and giant cells. This is the picture which we see in histopathology, and organisms may be identified within the macrophages sometime. So the macrophages is the part where it contains the organisms. So caseating necrosis surrounded by lymphocyte, giant cells and macrophages, and organism within the macrophages. Coming to the molecular diagnosis, PCR, this is one of the gold standard and very useful, but limited sources are there. Use it for detection of very small amount of mycobacterial DNA. This is the advantage, best advantage. Very small amount also can be detected. The sample is collected and it is incubated. DNA is extracted, amplified using DNA polymerase, and it is analyzed by electrophoresis on agarose gel and identified by ethidium bromide stain. So the DNA is extracted and we use DNA polymerase, and electrophoresis is done on an agarose gel, and we use the stain ethidium bromide stain. Sensitivity is 2 to 100% and specificity 60 to 100%. Advantages is it is very rapid, very sensitive, very specific, and requires very little DNA. Even the organisms are very less in the early stage or a very little infection is there, very sensitive and rapid and specific. Limitations are, as usual, contamination is one of the major limitation. So we can use nucleic acid probes and ligase chain reactions. These are the other methods. Coming to the indirect evidences like biochemical markers, we have an ADA level. ADA level correlates with the proliferation and differentiation of lymphocytes. That is the proliferation of lymphocytes and differentiation, which you correlate the ADA. Normal levels are 13 to 60 units per ml. And bromide partition test. CSF bromide levels less than 1.6 indicates tubercular meningitis. HPLC is one of the tests, and tuberculous acid detection by gas chromatography is one of the other method. Antibody detection in the immunodiagnosis, we do an antibody detection. Antibodies we detect it to the crude antigen, specific antigen, that is 35 kDa or P64, P32, 38 kDa, etc. Antigen detection is by protein antigens using polyclonal antibodies or monoclonal antibodies, and ELISA and rapid immunoassay tests are used. So antigen detection is mainly by protein containing antigen detected through ELISA or rapid immunoassay, and antibody is the antibodies to the antigen, like the following antibodies. Tuberculin skin test. It is a delayed type of hypersensitivity reaction. T cells are sensitized by prior infection and recruited to the skin. After undercoming the skin, they release the lymphokines there. The lymphokines induce the induration by the vasodilatation mechanism. There will be edema there, fibrin deposition will be seen, and recruitment of other inflammatory cells to the area. A negative MAN2 test does not rule out tuberculosis. So MAN2 is like an additional test which is a supporting evidence, but a negative test does not rule out, or a positive test does not imply that it is the tuberculosis case only. Procedure: locate the injection site, that is usually 2 to 4 inches below the elbow joint, prefer left side for identification. So select an area free of barriers like sores or scars should not be there. Prepare the syringe expiry date on the vial. Use a tuberculin syringe with a short gauze, that's 27 gauge needle with a short bevel, and fill the needle with 0.1 ml tuberculin. Inject tuberculin. Insert the needle slowly. Bevel up at an angle of 5 to 15 degrees. So needle bevel should be visible below the skin. So first you locate the area 2 to 4 inches below the elbow, usually left hand side. Take a tuberculin syringe. Check the vial for the expiry date. Take the PPD and 0.1 ml is taken, and a needle with short bevel is used and introduced at an angle of 5 to 15, and it should be visible on the skin surface. After that, you do the injection. A flat intradermal wheal of 8 to 10 mm diameter should appear. If not, repeat the injection at a site at least 2 inches or 5 centimeters away from the original site. So record all the information which is required. So record the date of administration and the time of administration also, how, and the test administration, injection site location details. 5 tuberculin units PPDs, 2 TU of tuberculin units RT23 available. So the result, when do you ask the patient to come for reply, is the 48 at the end of 48 hours and 72 hours of administration. The patient who doesn't return to us within 72 hours will be probably rescheduled for another tuberculin skin test. Next, coming to the reading of the tuberculin skin test. Inspect the site visually. First, do the site inspection under a good light, and after that you measure the induration, that is the thickening of the skin, not the erythema. It is not the reddening of the skin, it is the thickening of the skin. Palpate the induration. Use fingertips to find out the margins of induration. Mark induration. Use fingertips as a guide for marking the widest edges of induration across the forearm. Positive tuberculin skin test, induration of greater than 5 mm in children with close contact. So we should suspect if the induration is more than 5 mm. These are the conditions which are producing. Children, these are the conditions you should keep in your mind. The children, whether it's in close contact with a known case of tuberculosis or suspected case of tuberculosis, children suspected to have tuberculosis disease, or findings on chest X-ray consistent with active or previous tuberculosis disease, or clinical evidence of tuberculosis disease. All these things you have to think about if the following risk factors are there with the 5 mm of induration. The children receiving immunosuppressive therapy with immunosuppressive agents including HIV infection also is one of the major risk factors which you have to think about. And if the induration is greater than 10 mm, the risk factors are children at increased risk of disseminated TB, like children less than 4 years of age, and medical conditions like Hodgkin's disease or lymphoma, diabetes, or chronic renal failure or malnutrition. Children with increased exposure to TB, children born in high prevalence of world areas, children frequently exposed to adults who are HIV infected or homeless or users of illicit drugs, or migrant farm workers or nursing homes resident, children who travel to high prevalence regions of the world. If the induration is greater than 15 mm, then children 4 years of age or older without any risk factors, you can think it is a quite positive case of tuberculosis. So coming to the blood examination, so you have to send a general CBC and you have to look out for lymphocytosis, presence of lymphocytes. ESR will be quite elevated high, more than 100 usually. CSF in TB meningitis, macroscopy on examination, you can see a cobweb for coagulum formation when the CSF is let it stand for 30 minutes, and you can see a cobweb coagulum. Cytology, cell count of 60 to 400 cells per cubic mm will be present. So this is the range. The cells may range between this, and polymorphonuclear cells are seen, and later mononuclear cells are seen. Coming to the biochemistry, sugars are low or absent or normal. Proteins are more than 40 milligram per deciliter, and chlorides of less than 600. Tuberculin bacilli may be isolated if you take it for a smear. So the chest X-ray findings which we routinely examine are enlarged hilar lymph nodes is one of the classic feature which we see in our pediatric age group. The child may either have pneumonia or the child may develop bronchopneumonia. Pleural effusion might be seen. Medial shift, pleural effusion, tension cavity like mediastinal shift will be present. Cavitation, it is unusual in pediatric age group. In adults you can see obstructive emphysema, there will be hypertranslucence. Bronchiectasis may be observed, and miliary mottling are the findings. Abnormalities are often seen in the apical or posterior segments of upper lobe or superior segments of lower lobe, and they have an unusual appearance in HIV positive persons. It cannot confirm the diagnosis of TB. So already I've told you these are all the supportive tests. So what is the diagnostic algorithm for pediatric tuberculosis? Pulmonary TB suspected case. So when do you suspect? When there is fever or cough for 2 weeks, when there is no weight gain or loss of significant weight, history of contact with suspected tuberculosis or diagnosed TB, then you ask them whether you are able to expectorate or whether you want to produce sputum or not. If yes, examine the sputum smears. If no, you refer to the pediatrician for bronchial aspirate or gastric lavage. If yes, the two sputums, If the one of the two sputums or one or two positives are there, so sputum positive, that is a sputum positive direct case of tuberculosis, and go on with the anti-tubercular treatment. If the two sputum smears are negative, then you consider the other conditions like empyema, bronchopneumonia. So you give antibiotics for 10 to 14 days and see whether the cough is persisting or not. If the cough is persisting, then you repeat the two sputum examination again. If it is negative, you go for an X-ray. So the first line investigation sputum is done. You have treated with antibiotic, again cough is there, again two sputums you are taking, and if it is negative, go with an X-ray or Monto. Negative for TB, it is a negative case and suggestive of TB. If the X-ray or Monto suggestive of TB, then you call it as a sputum negative TB. So you will start anti-TB treatment. If the repeat two examinations, one or two positives are there, again it is a clear-cut sputum positive case of TB, and you have to give the treatment. So what are all the definitions of a new case, relapse, and treatment after default? New case, patient who had not taken ATT previously or taken for less than 4 weeks. That is the first case, or within 4 weeks you call it as a new case. Relapse, patient declared cured or completed therapy in the past and have evidence of recurrence. So who are completed, but now there is evidence, clear-cut evidence of recurrence, that is a relapse. Treatment after default is a patient who has taken treatment for 4 weeks and comes after interruption of treatment for 2 months and has active disease. So the patient is kept on treatment and also he has completed the new case, like 4 weeks is completed. After that he interrupts and after 2 months he comes with an active disease. So it should be interruption for at least 2 months must be present and active disease should be present. So failure to respond, a case of pediatric tuberculosis who fails to have bacteriological conversion to negative status or fails to respond clinically, or deterioration within after 12 weeks of complaint in intensive phase shall be deemed to have failed to respond. So after 12 weeks of treatment also the patient have failed to respond, or there is no conversion to negative status clinically or bacteriologically. So coming to the treatment part. So we categorize the cases now. Only two categories are there: new cases and previously treated cases. New cases, the types of patient are newly smear positive pulmonary TB, new smear negative pulmonary TB, new extrapulmonary tuberculosis. We have an intensive phase and continuation phase. Intensive phase is 2 HRZT and continuation is 4 months of HR. That is, I am discussing thrice weekly regimen. Previously treated cases are relapse, failure to respond, and treatment after default. These definitions we have discussed. The treatment is 215, 2 HRZES. All of them are covered, HRZES and plus 1 HRZE, and continuation phase 5 HRE. So role of intensive phase, what is the role of intensive phase? 4 drugs in the intensive phase which we are using are to achieve the rapid killing of the actively multiplying bacillary population, to eliminate naturally occurring drug resistant mutants, and to prevent further emergence of drug resistant mutants. And an optimal duration of at least 2 months in new cases is essential for an achieving a smear conversion of 90% or above. So it significantly reduces the infectiousness of patient. So role of continuation phase, fewer drugs for a longer time for elimination of persistence which are responsible for relapses. The duration, optimum duration of continuation phase is 4 months in new cases. So BCG, so it is discovered by Calmet and Calmet-Guerin. It is produced in Chennai Gundi. Danish 1331 is a strain. It is freeze dried and liquid vaccine stored at 2 to 4 degrees centigrade. Each vaccine has 0.1 to 0.4 million viable bacilli, and it is reconstituted with NS as distilled water as an irritant. Deconstituted vaccine should be used within 3 hours and the dose is 0.1 ml intradermal route on the left deltoid region. The timing, we should give it birth or at the time of earliest contact with the child but less than 1 year of age, preferably before 1 year. 25 or 26 cause needle intradermal left upper arm at insertion of deltoid is the area, and IUGR is never a reason for delaying vaccination. So it is 50% effective in preventing the pulmonary tuberculosis in adults and children, and the protective effect for disseminated and meningeal tuberculosis is 50 to 80%. So what are all the contraindications for BCG? So impaired immunity in leukemias or lymphomas or malignancies, HIV and congenital immunodeficiency, immunosuppressive therapy, any child on immunosuppressive therapy like steroid, antimetabolites, irradiation and alkylating agents. Any viral infections like measles, varicella, hepatitis B, viral infections are there. Give the vaccine 6 weeks later, 4 to 6 weeks after 1 month or 1.5 months. And if received immunoglobulin, postpone the vaccination to 3 months. So events following BCG vaccination are 0.1 intradermal rises a wheal of about 8 mm. Wheal get absorbed in half an hour. Induration at the site is persistent up to 3 weeks. And a lump of 6 to mm at 6th week, not painful but tender, softens with pus formation and discharges. It heals completely by 12 weeks with a scar of 5 to 7 mm. So this is the prevention, and BCG is the prevention, and we have discussed about the diagnostic tests and management of tuberculosis. Please save your chat, and those who have saved your chat can leave the session.